Okay, so my talk is on echocardiographic assessment of diastolic function. And let's begin. So the first thing we want to approach is like, why should we assess diastolic function in point of care ultrasound? Like, how is it useful for us? It is an advanced skill, requires some technical knowledge, and it has a so first, as you know, half of heart failure is heart failure with preserved ejection fraction. These people have normal systolic function and could have classic signs and symptoms of heart failure. So it's important to identify these patients to guide management appropriately. The risk factors for heart failure with preserved ejection fraction are very common, and hypertension, advanced age, diabetes, CKD, LVH. Patients that are, very many patients have these conditions is very prevalent. And as I said earlier, it could help in evaluating shortness of breath in people that have normal systolic function. There are objective parameters in diastolic dysfunction that could be looked at and said, you can say with some confidence that the filling pressure in the left atrium is actually elevated, which would change your differential about dyspnea if somebody is short of breath. And as I said, it can help evaluate LA filling pressure in both systolic and diastolic dysfunction. So patient with systolic heart failure may actually be relatively euvolemic, and their filling pressure pattern is going to be different than if they actually have, if they actually are in congestive heart failure, in which their filling pressures, which can be estimated by echocardiography, would be different. So as we know, like B-lines do not mean fluid. Okay, I mean, that's just one of the many possibilities. So if somebody, say, has, high heart failure, diastolic or systolic, and they have like a lot of B-lines, you can look at the heart to get a sense of what the LA filling pressure is. And if it's elevated, that you could correlate the B-lines with like high filling pressure in the left atrium, and make an argument for this may be more heart failure related pulmonary edema or B-lines. Or it could also be present in the setting of, say, ARDS. If you have ARDS, you're technically supposed to diagnose ARDS in the absence of left atrial filling pressures, like reduced normal, near normal LA filling pressure. So you could use diastolic assessment of the left atrium, or even in systolic heart failure, you can identify diastolic filling pressures in those situations, is to rule out heart failure, or say that there could be a component of heart failure in ARDS or pulmonary fibrosis, for example. So first, I want to talk about what are the components of diastology. And there are many, and some of them are like, in majority of the patients, you can identify, diastolic dysfunction by knowing of 4 major parameters, okay? But not in every single patient, okay? There are advanced applications which are not going to be part of the talk, like Valsalva maneuver, isovolumetric relaxation, pulmonary venous Doppler. I think it's really outside the scope of point of care ultrasound. But we'll talk about the first one, is mitral inflow velocity. So this is basically a pulse wave Doppler that's placed at the gate of the mitral valve leaflet, tips of the mitral valve leaflet in the left ventricle. And as you know, the pulse wave Doppler only is range specific, so you can give you a sense of the velocity of blood at a certain point, at a certain depth. So we identify that. Part of that is tissue Doppler, which tells you the velocity of myocardium, how swiftly is relaxing. And then TR jet, which is identified by continuous wave Doppler. So this is an example of pulse wave Doppler. Let me see if I can screen. This is an example of continuous wave Doppler. Continuous wave Doppler, the envelope is like filled in, whereas in a good pulse wave Doppler signal, the envelope is brighter on the edges and darker inside. And left atrial volume index. Now, this is a way of like quantifying left atrial size, and it's indexed to body surface area. So we'll talk about these in more detail, but I wanted to actually go over this. I actually made a recording of. Go ahead. All right, so once we have this chamber view, I made a recording of, thanks Dr. Singh and Dr. Witherell were there helping me with this, of actually how to assess diastolic dysfunction, like how to actually get the pulse wave Doppler in the mitral and the tissue Doppler on a real patient. And so I'll just play this so it'll be easy for all us to be on the same page with this. You can click on pulse wave Doppler, place the gate at the tip of the mitral valve, right here. And we can get this pattern. This is the E and the A waves. Freeze this view. Try and find a good envelope like this one. And measure the E and the A peak velocities. The acceleration time as well. The first wave is the E, second is the A. It gives you the velocities here and E to A ratio. Next step is to get tissue Doppler, for which you have to press this button, tissue Doppler, and then place the sample gate at the medial mitral annulus. You get this tracing. You're interested in the wave below the baseline. And when you freeze this, similarly measure these waves are called the E and the A prime. So this is the E prime, and the A prime is the second wave. You could use any envelope that's good, and then you get E prime and E over E prime ratio. So use this as well. You should also see there's a tricuspid regurgitation jet, which we can see here. I can put color on it. Many people don't have a TR jet. But you try and put it right at the right atrium and try and really visualize the TR jet here, which would be below the baseline. It looks like he has one. That's all right. We'll talk about all these in more detail. So the first thing that we are identifying is the transmitral inflow velocity. Now this is basically quantifying the filling of left ventricle from left atrium, during filling, there's like early diastolic filling and then late diastolic filling. And late diastolic filling is basically represents the atrial contraction. That's near the end. The rest of the blood, most of the blood that's left in the left atrium is pushed back in the left ventricle. And so in order to get this, you need to acquire an apical 4-chamber view. And I said you need to place the pulse wave Doppler gate at the tips of the mitral valve in the left ventricle. The Doppler angle needs to be as parallel as possible to the flow of blood. Better to have a Doppler angle less than 20 degrees. Otherwise, you may underestimate the true velocities. And then if you look here at this image on the, I don't even have a cursor here, at the bottom right of the screen, you'll get two waves, E and A waves. And then the E wave is supposed to be bigger than the A wave in normal. And so the E wave represents early diastolic filling, and the A wave represents the filling as a result of atrial contraction. And you could see that they occur like before the QRS complex on the trace EKG tracing, and that's because they're actually occurring in diastole. So if you have an EKG lead, you can also use that to be absolutely certain that you're looking at E and A waves, because these are diastolic patterns. Now, this is actually going into more detail about how this occurs. So there are actually 4 different patterns that you have to be familiar with. There's normal pattern on the far left of the screen where the E is more than the A wave, okay? And then as diastolic dysfunction gets worse, you get a reversal of E and A waves. The A becomes higher than the E, and then that's grade 1. And then in grade 2, it actually goes back to looking like it was normal. So this is actually called pseudonormal. Okay, let me just get these. And then the third one is where the E is much higher than the A wave. And that is a restrictive filling, which is grade 3. So actually I want to go over these waveforms. So in the top of the image, there is hang on one second. I can't really see I can't really see my cursor here. So yeah, I'll just so in the top of the image under normal, if you look at the tracing pattern, you see like what happens in normal is that most of the filling occurs in early diastole. And you can see the left atrium. When the pressure of the left atrium, like right when diastole starts, the LV curve actually goes below the LA curve, and that's where the gradient occurs, and most of the filling occurs at that time. And then there's like the left atrium and the left ventricle curves are very close to each other. Can everybody see what I'm talking about? Because I don't really have a cursor on the. Okay, all right. Can you see my mouse now? Hello?
Yeah,
I can see the map.
Okay. So this is the systolic part. This is the diastolic part of the cardiac cycle. So in this case, you have a gradient, and the early filling occurs here. And then here there's diastasis, where there's not much filling. And then near the end, when the atrial kick occurs, the pressure in the left atrium is above the left ventricle, and there's actually some filling over here as well. So this is normal pattern. As the left ventricle gets stiffer, okay, the next step is impaired relax. There's the next grade is impaired relaxation. And in this case, the left atrial pressure is actually still normal. Like if you look at the flow pattern for LA, the pressure pattern for LA is the same as the pressure over here, but there's more resistance to filling from the left ventricle. So you can see here, initially this filling occurs, but there's a greater deceleration time. Like the slope is not as sharp as this. It's like a more, it takes longer for it to come back to down because of greater resistance to filling in the LV. And you can represent it by the fact that the curve here is also like not as steep as this. And then actually at that time, most of the filling does occur in the atrial kick portion. And that's represented by this curve here. So, and as this gets worse, the pressure in the left atrium actually gets higher because of hypertrophy of the left atrium, and there's greater pressure as the LV is getting less and less compliant and more resistant to filling. So then actually it reverses back to how it was, like normal, where you have higher pressure in the left atrium. And so if you look at this grade 2, which is also called pseudonormal and normal, they look the same. The difference is the actual pressures in the left atrium and left ventricle are higher compared to the left ventricle, left atrium pressures in the normal pattern. And so that's represented here. And as things get worse, in the most advanced case, you get something called grade 3, where the E wave is much higher than the A wave. And that's represented by this flow pattern here, where all the pressures are really high, but and then most of the blood is being pushed into the left ventricle by left atrium. This is so in this case, the E over A ratio is like high, more than 2. In this case, it's less than 1, usually around 0.8. Okay, so this is the different terminologies that are used for this mitral inflow pattern. So here is an example of impaired relaxation. You look at the E and the A waves, the A is above E. Here's an example of restrictive or grade 3 diastolic dysfunction, where the E wave is much higher than the A wave, okay, more than 2 to 1. And here's an example of normal, where the E wave and the A wave are, they're, in that ratio where the ratio is less than 1. But it could be normal or pseudonormal. All right, so identifying the E and the A waves just gives you the mitral, the transmitral velocity of blood, okay, entering the left ventricle. And that's just one component of diastolic dysfunction. Now, next step is actually to identify the tissue Doppler velocity of the myocardium, right? So this is part of pulse wave Doppler. The idea here is to be able to quantify like how fast the myocardium is relaxing. So it makes intuitive sense that if you actually have a diastolic dysfunctional myocardium, it's stiff, it's not compliant, it doesn't relax as easily, the speed with which, okay, the myocardium relaxes is going to be low, okay? And that's what you're trying to figure out. So in order to do this, you actually have to change the setting on the machine to make it a tissue Doppler. So you're actually looking at high amplitude, low velocity signals. And you place the pulse wave gate at the lateral annulus and medial annulus. You take the average, or you could just do one, medial or lateral, okay? And then at the annulus, you press the tissue pulse wave, and you get this kind of pattern. So if you notice, the y-axis here, the units are in centimeters per second, okay? Whereas for the E and the A, it's actually in 50, 60, 100, okay? That's because the myocardium doesn't relax it relaxes at these relatively smaller like numbers. So you can this gives you like basically what is the E prime, okay, and is represented by the E prime. So the E prime at this location in the medial mitral annulus, normal is about 7 centimeters per second, and for lateral is more than 10 centimeters per second. So it makes sense that if somebody has like worse diastolic dysfunction, relaxation is going to be slower. So these values are going to be less than 7, less than 10. Okay, these are considered normal values. In a percentage of normal healthy people have above 7, above 10. So if you have worse function, it's going to be less than that. So this is this is one of the next steps that you have to do in this. So you can use the average of the medial and the lateral mitral annulus, or you could just use individual velocities, but keeping in mind that they have different cutoffs. Okay, so this is let me see if I can. Yeah, so this my cursor disappears when I just maximize the screen, so I can't really point at things. So I'll just go this way. Sorry about that. All right, this is an example. So I want to just take a look at this. Fine. This is an example of normal myocardial relaxation. You can see the E wave here. This is 10. So this is like above 10 at the medial. Here's also example of normal. This is an example of abnormal myocardial relaxation where your cutoff here is at 4. Similarly over here. Okay, so I want to make the point that these go together, right? So in normal pattern, you'll have the E and A signals on the left, but the E prime velocity, which is the first negative deflection below the baseline, okay, that's going to be high. But as diastolic dysfunction, like more than 7, more than 10, as it gets worse, the E prime velocities are going to go lower and lower. So in grade 3, it should be less than 7 or less than 10, okay? And one way to separate normal from pseudonormal is that in normal, the E prime is going to be above 7 or above 10, okay, normal, but in pseudonormal is actually going to be less than 7, less than 10, okay? That would be an indication that this patient has pseudonormal or grade 2 diastolic dysfunction. Actually, let me just see if, okay. And I just went over these images already. Okay, so I had planned this to be an animation, so let me see if I can work around this. All right, so there's something called, so one of the parameters you need to know is E over E prime, okay? So E over E prime actually represents, it correlates with filling pressure. And that's what I'm trying to show over here, where you have a E over E prime ratio on the x-axis, the LA pressure on the y-axis. Like as the ratio increases, the LA pressure also increases, okay? Up to a certain point, like about 15, where it's not like a linear correlation. This is like nearly a linear correlation, not perfect, but so it's very specific, okay, but it's not sensitive. In other words, if somebody had the E over E prime ratio above 15, you can be fairly sure that they have some degree of diastolic dysfunction. But if they have an E over E prime ratio less than 15, you cannot rule it out, okay? You could still have other markers that you have to look at. And here's another example of showing that E over E prime ratio correlates with mean left ventricular diastolic pressure. Again, this is the empty dot and the black dot represent heart failure with preserved and systolic and reduced ejection fractions, so in both cases. Okay, so for our purposes, the average of the E prime, E over E prime, medial and lateral annulus, the cutoff is more than 14. Okay, so what is left atrial filling pressure? So I got this really cool picture. Let me see if I can play this here and then show you. Okay. Oops. What happened to this? Sorry about that. I'll just skip it for now. All right, so the next is assessing your TR jet velocity. So the idea is if you have high left atrial filling pressure, that's going to backflow into the pulmonary veins, and then you'll have a higher pulmonary artery pressures as well. So we don't actually calculate the pulmonary artery systolic pressure. We just look at the TR jet, okay? Because the idea is that higher the TR jet, greater the velocity of the maximum velocity of TR jet is going to be the higher likelihood that it's going to be you have a higher pulmonary artery systolic pressure. So this is done with continuous wave Doppler. Okay, you can do it in 3 different ways. The most common way is to do the apical 4-chamber view, where you have the Doppler right here, insonating in this angle, and then you turn on your continuous wave Doppler, and you get this filled-in signal. Okay, so continuous wave Doppler is really good for figuring out like really high velocities. Okay, there's no aliasing, and it doesn't, it just tells you all the velocities across this trajectory. So you have to know your anatomy. You have to know what different, so you have to look at the color flow as well to see like what's actually contributing to your velocity in this area. So we know the tricuspid valve is here, right ventricle is here. By the way, this is the tricuspid valve is here, and this is the right ventricle. So this is going to be the TR velocity is going to be picked up in this angle. So you get a filled in envelope, and then you could get the maximum velocity and multiply that by 4, square and multiplied by 4, that usually gives you the delta P. You just need the TR maximum velocity jet. So you can also get it from parasternal short axis. Here's your aortic valve, left atrium, right atrium, right ventricle. So this is tricuspid valve. So you could have it here, and then also in right ventricle inflow view, where you could get a tricuspid velocity. Okay, and then the left atrial volume index. Now, so this is a way of like, figuring out like how big the left atrium is and quantifying that. So it gives you a sense of the chronicity of left atrial volume or pressure overload. The idea is if you have chronic pressure overload from like say LVH or like chronic valvular regurgitation present, you're going to have left atrial hypertrophy, and normal cutoff is like 34 milliliters per meter square. The way this is done is that you want to trace the endocardial border at end systole for in the apical 4 and in the apical 2 view. So in this case, in end systole, you trace the endocardial border, and then using Simpson's method, which is basically a way of it divides this area into like multiple discs and then summates the discs. So when you get this view, you get a volume here, and then you turn it about 90 degrees counterclockwise, and you get an apical 2 chamber view, which gives you the anterior and the posterior wall of the left ventricle. And then you basically trace the endocardial border here, and then you get a value, and then you divide that with body surface area. I don't usually see this done in like point of care. I haven't done it personally. I would say for our purposes, if you just look at left atrium and you say this, you can see it's enlarged, your LAVI is probably going to be above 34, okay? So once you have all this information, like what do you do with it? Okay, how do you actually work with this? So these 4 values is how you assess the majority cases. So if you have like normal EF, if your E over E prime ratio is more than 14, your septal E prime velocity is less than 7, lateral is less than 10, your TR is more than 2.8, or LAVI is more than 34. If any 3 of these are normal, okay, then you have normal diastolic dysfunction, diastolic function, and you're done, okay? If 3 or more of these are abnormal, okay, then you have diastolic dysfunction, then you have to grade it, okay? If you have 2 and 2, then you determine it, you need to know other parameters like, pulmonary venous inflow, and that's primarily the one, and IVRT, these things that are more advanced, then we use those to identify which direction are we going to go. So let's say you identify these things, your E over E prime is more than 14, okay, and you have a TR jet, then you can move, and then the LA is large, you can go to the next step. Now you have to grade the diastolic dysfunction. So how do you grade? This is, by the way, right from the American Society of Echocardiography, which is what we use. And actually, when I went to the critical care echo board review, we were using this exact algorithm. So this is very relevant for point of care ultrasound because our intensivist colleagues are using the same algorithm to grade diastolic dysfunction. So let's say you have like heart failure with depressed EF, or if you have a normal EF with diastolic dysfunction, this algorithm applies, okay? Okay, but once you have somebody with systolic heart failure, they cannot have normal diastolic function. They have to have abnormal diastolic dysfunction. It could be grade 1, grade 2, or grade 3, but so anyone with low EF, you're already in this algorithm. You don't worry about the first algorithm, okay? And somebody has normal EF, and you suspect that this patient may have diastolic dysfunction based on the LAVI, based on the E prime, okay? You come here, okay? And the first thing you look at is what the mitral inflow pattern at this point. If the E over A ratio is less than 0.8 and the E is less than 50 centimeters per second, you have basically normal or grade 1 diastolic dysfunction. These people have normal left atrial pressures, okay? So if you have grade 1, okay, this is the pattern where the A is above the E, okay, you could be reasonably sure that the filling pressure is not very, very high. It's not like 20, not 50, it should be on the lower side. So that's something, you normally get with the invasive hemodynamic monitoring. So you can get that with the echo itself. If somebody has an E over A ratio more than 2, okay, that's when the E is really high, A is very small, you already have grade 3. Okay, so grade 3 is the most advanced, and the LAP filling pressures are pretty high. Everything else kind of falls in between, right? So this box is between the extremes. Once you come here, then you look at these 3 criteria. Okay, what's the E over E prime ratio? what's the TR velocity, and how big is the LA volume index. Okay, if two of these three are negative, okay, if only one is positive, then you have normal, grade 1. Normal LAP, grade 1. If two of these three are positive, you have grade 2. Okay, even in this algorithm, you cannot quantify every single one with a certain grade. Okay, you need at this point, you need, and if you have 1 and 1, you need pulmonary venous flow, you need IVRT, more things that are more advanced for the point of care ultrasound. Okay, so how to separate normal from pseudo? These look the same, normal and pseudonormal. So how do you know if somebody has normal or pseudonormal filling? All right. So if they have like low ejection fraction, if their left atrium is enlarged, if they have LVH, so anything that on the 2D image that looks abnormal, they cannot have normal diastolic function. Okay, if they have a normal looking pattern, they have pseudonormal. Okay, so they have elevated LAP, LA filling pressure. One more thing that you can do is you can do a Valsalva. Okay, let's say this patient has a normal filling pattern. Okay, and you don't know if it's normal or abnormal. Okay, so you can have them strain, and during the strain phase, keep looking at the mitral inflow, and if they actually have pseudonormal, they're going to reverse. The E is going to get less, and the A is going to go higher. Okay, so they will become impaired relaxation, the grade 1, and that tells you that they actually have pseudonormal. Okay, normally what happens if you strain, both of these peaks come down. They both reduce in size. But if you have pseudonormal, they reverse. Of course, you can look at tissue Doppler, right? So this is normal. You look at the E prime. This is pseudonormal. In grade 2, with the E prime is rho. So in grade 2, your E prime is going to be reduced. Okay, so your E over E prime ratio is going to be high. This is another clip from sort of a picture from POCUS 101, where you can look at the E prime in grade 2 is less than 8, and then in E prime in normal is more than 8. So. All right, so some questions. This patient is coming in, this 67-year-old man is coming in with dyspnea and atrial fibrillation. So how would you grade this diastolic dysfunction? Is it normal? Is it grade 1, impaired relaxation? Is it grade 2, pseudonormal? Is it grade 3, which is restrictive pattern, or is it E? We cannot figure this out. Any takers? Okay, so in this case, if you look at this is the E and the A velocities. Okay, this is mitral inflow. So, this is the baseline. Left atrium is filling in left ventricle. So the facing is above the baseline because it's coming towards your probe. And you look at the E wave, it's really large. Okay, it's like, this is in meters per second, probably around, 110 centimeters per second. Look at the A wave, it's minuscule. So the E over A ratio is more than 2, much more than 2, right? So this is already in the advanced range. Okay, if you go back to this algorithm, you're already here, grade 3. Now, to confirm that, you can also take a look at the E prime is only 3. Okay, this is like in the medial mitral annulus. So normal in this would be more than 7. So if you look at the E over E prime ratio, it's going to be pretty high, right? So that already tells you it's going to be advanced diastolic dysfunction grade 3. Let's see here. Okay, so this was supposed to be an animation too. Okay, yeah, so let's start here. This is another case where you have a 30-year-old man who presents with shortness of breath. Okay, so here's the E and A pattern on the left, bottom left of the screen. And then you have a 2D image on the right. I know his EF is normal. So, okay, so, and then you look at the E in the middle of the screen. Okay, there's the septal and lateral E primes. So what about this? So in this case, the left atrial volume index is less than 34. Okay, that's one thing you already know. And you look at the E and the A ratios on the left, and you look at the E primes in the middle. So the E prime already looks like it's more than 7, more than 10. Here it looks like it's 12, and bottom looks like almost as 15. Okay, so that's normal. And what about the E over A ratio on the left? In this case, you don't really see an A wave, right? It looks like it could be advanced diastolic dysfunction. Okay, but actually, I want to introduce a second idea here. Okay, I've shown this image before. On the left of the screen, you see something called supernormal. Okay, so these are people that are young and healthy. Okay, they have very very compliant hearts. So if their when their left ventricle relaxes, it's sucking the blood at such high intensity, like such great speed, that you actually get most of the filling in the early diastolic phase, right? So it looks like it's grade 3 because the E over A ratio is like higher, is 2:1, 3:1, but they're not. They don't have diastolic dysfunction. First, their 2D echo is going to look normal, and second, look at the E prime. It's really very impressive. Now compare that E prime to grade 3. Okay, so this is one way you can not to get confused with people that are young and healthy and they come with shortness of breath and they have a mitral inflow that looks like it's grade 3, but it's not actually abnormal diastolic function. Is supernormal, and the way you can separate that is by normal appearing 2D echo, okay, and high E prime, 10, 15, 12, okay, above the normal. Like in grade 3, you expect the E prime to be low, 3, 2, 4, etc. Okay, one more thing I want to make, a point that I want to make is that diastolic dysfunction is not static, okay, it changes. Now the E prime is basically represents your intrinsic myocardial dysfunction. So it's not going to change. It's how slowly, how restrictively your myocardium is relaxing, okay? But the filling pressure can change of the left atrium, right? As you get, if you're in heart failure, for example, okay, and your LA filling pressure is really high, okay, you can get pulmonary edema and you could be at grade 3, okay? But if you diurese somebody, you could actually bring your E and A ratios down to grade 1, impaired relaxation. And if you have heart failure, systolic or diastolic, you can never have normal diastolic function. Okay, so even in patients who have systolic heart failure, the best diastolic dysfunction pattern they can get is grade 1. Okay, normal LA filling pressures. They can never have normal. But the best you can get is grade 1, which is abnormal relaxation. They can never have normal. So the top E and A ratios are actually preload dependent, whereas the bottom ones, the E and E prime, are preload independent. Okay. Now, what's sort of the what are the limitations of assessing diastolic dysfunction? If you have mitral valve prosthesis or MAC, which is mitral annular calcification, you can't use E prime. That kind of makes sense because that E prime is representing like calcium or the metal in the mitral valve or the bioprosthetic mitral valve. It's not representing myocardial relaxation. Okay, so you can't really use E over E prime in people that have mitral valve prosthesis or MAC. Same thing with aortic valve prosthesis. Or if you have significant mitral stenosis and mitral regurg, the dynamics of the mitral annulus movement are going to be affected. Okay, if you have significant tachycardia, then the E and the A waves confuse, and it can be difficult for you to separate them out. Okay, it's not impossible to assess diastolic dysfunction, but when tachycardia occurs, diastolic filling time reduces, so the E and the A waves can fuse. Next is if you have a big difference between medial and lateral E prime velocity, that's why it's important to check both. You may want to be careful because if you have RV dysfunction, that medial mitral valve may represent the RV failure, and it's not going to move as effectively because the RV is not moving. So you may want to use lateral in those situations. Okay. So and finally, if you have like a wall motion abnormality that affects the septum, It could affect the medial mitral valve, or or the lateral wall if that's the wall motion abnormalities over there. If you have pacemakers, that could also affect it. All right, so thank you, Dr. Singh and Dr. Witherell, for helping me record that video, and that's all I have. Any questions?